Well, good morning, all. I'm Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we'll go ahead and get started with some logistics and then introductions of today's speaker. Please be sure to join us next week. We'll be hosting the talk, Women and Acute Coronary Syndrome, Myths, Truths, and Improving Our Practice, given by Dr. Kieran Beyer. Many of you know that Grand Rounds is a collaboration between Providence St. Vincent and Providence Portland Medical Center. We are here live today at Souther Auditorium at St. Vincent's, where we typically meet at 8 a.m. on Tuesdays. We are sometimes live at Providence Portland, also on Tuesdays at noon. Welcome to those of you who are joining us virtually on the Teams Live platform. You can earn CME credit by being here in the room, by watching live virtual, or by watching a recording of the event. If you look at the Grand Rounds invite each week, it will tell you exactly where and when we will be meeting, and also has the link to watch the recording. And for those of you who are joining us virtually, please go ahead and post any questions or comments, and I'll mostly hold those until the end as time permits. And now to introduce today's speaker. We are joined by Dr. Ty Duffield, a behavioral sleep medicine specialist for Providence Medical Group. He originally trained as a neuropsychologist with an early career focus researching the relationship between cognition and sleep, while also providing clinical neuropsychology care to both primary care and specialty settings. He progressively increased sleep treatment services and ultimately made the career transition to full-time sleep psychology and with Providence 2 years ago. Dr. Duffield brings tremendous expertise in this complex and important clinical topic, and soon will sit for the board examination to become a diplomat in behavioral sleep medicine. Thank you so much, Dr. Duffield.
Thank you. Thank you, everyone. Also wanted to, is it this mic? This mic. Also wanted to thank Dr. Allison Ayak for inviting me to speak today, and just her general thoughtfulness and evidence-based practice as it relates to sleep and primary care. Okay, so what is sleep? We don't have an agreed upon definition yet because we still don't really know. But one of the primary definitions given recently by Michael Grandner and one of his neuroscience colleagues in Science. Dr. Grandner is at University of Arizona and one of the godfathers of behavioral sleep medicine, because it's naturally occurring, it's reversible, it's perceptual disengagement from our world in a 24-hour period. The importance of immobility during this time. We'll talk more about this during treatment of nightmare disorders. And it's driven by both homeostatic and circadian factors. It's a set of interrelated physiologic processes, but it's much more than the amalgam of them. Our modern society is not conducive to sleep. Work demands, not conducive to sleep. Technology, not conducive to sleep. Particularly in westernized cultures, particularly in the United States, oftentimes sleep is sacrificed. And it's not a unitary construct. The American Heart Association recently added sleep duration to their Life's Essential 8, and then spend a whole paper talking about how they should have way more than just one feature of sleep, and that the importance of understanding sleep is multidimensional. So when I'm treating someone, the first understanding of how they're sleeping is through the sleep diary. And what do I get a pattern of statistically when they send that to me for the first time? What I'm really, really paying attention to is their regularity, rhythmicity. They'll come in with the second feature and they'll tell me all about their satisfaction and quality. That's the most important outcome. That's what we get to in the lattermost portion of treatment. What they'll come to you talking about is how their sleep is impacting their daily functioning. Most importantly, the specific symptom constellation or symptom burden, right? That really kind of gets at that alertness, uh, factor, right? How is sleep not only impacting my mood, but my cognition, and how I interface in my world? And it impacts everything, right? We all can agree upon that. That's not new information to you all. But if there is sleep disturbance, that progresses to insomnia, and then depending on the severity of the insomnia and all the associated co-occurring sleep conditions, it begins to impact all health, right? And you can't just understand it from the primary care lens of treating health conditions, though. You have to understand it from an ecological perspective, right? From an individual, from a societal, and then from a much more macro level. This is how we interface with each other, I believe, in terms of interdisciplinary care, right? Primary care provider, behavioral sleep medicine provider, local social worker, case manager, etc. All right, so what's insomnia? We've talked about what sleep is. So insomnia is sleep onset, sleep maintenance difficulties, at least 3 days a week, that progress or that perpetuate for at least 3 months. Again, patients are going to be coming to you talking about this, right? And so I see a variety of workups that can follow, right? And again, if it goes on long enough, then patients start to meet diagnostic criteria for other downstream conditions, right? Cardiovascular conditions, metabolic conditions. But at some point, they begin to experience these symptoms from sleep disturbance that evolves into insomnia. So you'll oftentimes have a patient at the intake say, well, I have insomnia because I have generalized anxiety disorder. I have insomnia because I have ADHD. No, right? Conceptually, that is not why you have insomnia. That creates risk to develop insomnia. That's exemplified here in the Spielman's 3P model, perpetuating factors, right? So genetically driven predisposition, things like, high trait loading on neuroticism, or childhood history of trauma, or a eveningness circadian tendency, right? Colloquially, a night owl. But it's not just that. Then you have precipitating events, right? Like car accident or a knee surgery. And you have this diathesis, and with enough stressors that evolve or compound will push someone over into chronic insomnia. And what happens that then the insomnia stays after whatever the stressor or associated medical condition is resolved or better managed? It's how the person changes their behaviors and thoughts in relation to that sleep disturbance. How did they cope, right? Not only at night, but during the day as well. So this is where you start to see some of the changes to thoughts and beliefs around sleep, not just behaviors. So it's the compensation game, right? I got 4 hours of sleep on Tuesday, so I sleep in Wednesday morning. I take a big nap, or I go to bed much earlier Wednesday night, or I start worrying about sleep during the day. I start thinking about it. I start canceling normal life events. I start to over-attend to sleep or over-focus on sleep. All of that then, over time, relates to hyperarousal in the sleep environment. This is both cognitively, right, kind of thinking about sleep or thinking about work when you're staring at the ceiling. Affectively, right, worried that I'm not sleeping, worried about, finances right now. I'm hearing that a lot, as you can imagine. But it's also physiologic as well. I mean, it's very clear beta intrusions on polysomnography and moderate and severe insomnia that we just don't have time to get to today. But it's multifaceted is the point. Okay, so the how. How do we treat insomnia? Well, international gold standard is CBTI. What is that, right? It's a multi-component treatment package that targets those changes in behaviors and thoughts that really perpetuate insomnia, again, regardless of the stress diathesis risk factors that push someone over into diagnostic criteria. Now, I like to talk about the big three with my patients. So first, we need to consolidate your sleep phase, right? Make it as continuous as possible, regardless of how much sleep you're getting. That is first and foremost, foundationally, how we improve your sense of sleep quality. Then we progressively get you more sleep, hopefully get you to your personal sleep need, and then get you into circadian alignment when you should be sleeping in a 24-hour period. All of those factors have inter-individual diversity or variability. Okay, so if you get anything from today, it's that CBTI is not just sleep hygiene, right? I see this all the time. It is a component of the multi-component treatment package. It is the least efficacious. It essentially, if you have no sleep hygiene in your treatment package, it won't change your outcomes at all. I mean, it's good for general sleep health, right? Like, don't drink coffee at night. Don't do a rigorous workout right before bedtime, like just basic things. But it's meaningless when it comes to insomnia treatment. But I see all the time referring for sleep hygiene, referring for sleep hygiene. Okay. So some recent descriptions in the art that I just thought I would add. So that first one there was from a boarded sleep medicine provider recently who refers to me all the time. And I saw that and I was just like, come on, man, really? And then the second one, it just made me laugh out loud. I thought it was hilarious. Another specialty provider, I think it was an OBGYN for a female patient who was starting HRT, but I just thought that was hilarious, doing the sleep psychology thing. Okay. So what's the support for CBTI? Why is it the international gold standard? So most treatment protocols are 4 to 8 appointments, usually with 2 to 3 week intervals in between. I usually do 6 to 8. There's a reason for that. But there's of the dismantling research showing that a minimum of 4 appointments for sufficient clinical efficacy or baseline efficacy. It is comparable outcomes to sedative hypnotics in the short term, and what makes it superior is long-term outcomes or the risk of an insomnia recurrence in the future, not even comparable. Because what do we give patients? A skill set the next time they have normal variability in sleep health, like your kid gets sick or your savings get drained, or et cetera, et cetera. All right, so about 70 and 80% of individuals have a reduction in the severity of their insomnia. About 40 to 50 go into remission. They don't have insomnia anymore. Obviously, much lower side effect profile compared to medications. And sleep restriction can be difficult, but there's low to no evidence to show that there's harm. I get asked this all the time because it is difficult, and you are going to feel worse through that process, but it is short-lived. By worse, I mean we're increasing your sleep drive during the day, so you sleep more at night. And it's just paradoxical for a lot of people that they feel worse, even though they can start getting more sleep in the process. And it's supported by all major medical organizations internationally at this point, as you can see. Okay, so I think this is really important because I get asked this all the time too. Well, what about CBTI and congestive heart failure or cystic fibrosis or, et cetera, et cetera, et cetera. These authors in 2021, I would doubt it's different now in 2026, that there's any research to show that it doesn't work in any particular medical condition. It works. Okay. Insomnia costs employers and families and healthcare system a lot of money, so we should treat it. And even if you're not meeting the hard and fast insomnia diagnostic criteria, a lot of people can have recurrent insomnia. They come in and out, in and out, in and out. There's always relevance long-term for treating in terms of prevention of future healthcare risk, which gets to what are the functions of sleep. I'm not going to read these for you, but we spend a third of our life sleeping. any given circadian period, 20 to 40% of the day, we're sleeping. It's important, right? So I don't know how shocking this is to any of you. Maybe it's not at all. But recent research showing that about half of your patients will meet criteria for insomnia on any given annual visit. And insomnia obviously has a bi-directional relationship with whatever medical or psychiatric comorbidity, the patient or you deem is associated with it. But we have growing research to show that in terms of causal directionality, it's much more often the case that sleep difficulties start and persist, and then at some point, onset of first major depression or blood pressure goes up, et cetera, et cetera. And it's just often not being talked about at primary care visits. This is pretty well replicated finding. Okay, so understanding the functions of sleep, and if we treat insomnia, do we get the reverse effect? Are there collateral benefit to what you talk about at your appointments? Yes, there is, right? Maybe you can reduce that lisinopril prescription dose. Maybe we don't need to be on modafinil anymore after we start PAP therapy for comorbid sleep apnea, et cetera, et cetera. Less missed work because immune function is normalized. It's preventative medicine. So it's treating circadian rhythm disorders. So I also work with a lot of shift workers in healthcare, a lot of shift workers in tech. This is a whole separate competency. About 20% of American workers don't work standard hours. As you can see, their health suffers in every category. I just went to a circadian rhythm conference at OHSU last month, and they actually, one of the presenters showed this, and this figure just blew me away. Particularly this, right? Like, there's an expiration date on shift work. At some point, there's a strong likelihood that you'll develop cancer. Okay, so what's another factor that's a distinct phenomena from insomnia? This is often conflated by patients, but equally important, if not more so than treating insomnia, and that's sleep duration, as we've talked about. There's just a lack of emphasis and potentially opportunity in America right now to get a normal amount of sleep. So this is from an old socialized medicine kind of review from Europe in 2005, kind of showing more, adult sleep need about 7 to 9 hours, right? Some people need 7 hours to feel good the next day. Some people need 8, etc. Some of the more recent research is 7 to 8, and then kind of a smaller percentage up to 9. Once it's more than 9 in a 24-hour period, that's really important. In a 24-hour period, we've kind of moved in westernized cultures where we have to get it all at once, right? We're not allotted time to nap. Napping's actually important if done the right way, but it's almost always problematic if it's more than 9 hours a day. This was a recent publication by JAMA. I used to work with a lot of athletes at my old employer, high school all the way up to pro. Young athletes are just overscheduled like that. That's really clear in the literature, right? Sports are like year round now, which I think is just absolutely ridiculous, but there just wasn't opportunity to sleep, right? You can only get practice rink time at 9 at night. Okay, well then you got to go home and eat and shower, and then you got to finish your homework, right? There's just not time to sleep. But this, like I had to sit down when I read this. So insufficient sleep has progressed up to almost 80% in youth in America. And it's driven by an increase in very short sleep status. So what you can see for that age group, right, adolescent teen, It's more 8 to 10 hours sleep need. So very short sleep status is characterized as less than 5. For adults, it's less than 4. But this is a problem. Like this is a health emergency to me. So yeah, I just don't know. I just don't know what's happening here. Like they saw this increase across all demographic groups, not just the young people that had associated mental health conditions, and we don't really know what's going on. But it's systemic, right? Is the point? It's not just individual behaviors. It's not just that they're on Facebook too long at night, but this is a big problem. Okay, so then what is a behavioral sleep medicine specialist, right? What I do, more than just knowing CBTI. A lot of mental health providers at your local clinic will have a basic CBTI training. That's really important. We need more providers who understand how to treat insomnia. But there's much more to treating kind of health conditions generally. This is a scope of practice put out by the organization that I'll be boarded with in the very near future. It's really understanding sleep medicine more broadly and behavior change, right? So what do I primarily treat? Insomnia, circadian rhythm disorders, nightmare disorders. We don't have as much efficacy to treat hypersomnia, but there is some, and I get very few referrals for hypersomnia. I also do a lot of sleep aid tapers. That's actually why I got asked to come here and speak, and so I'll be talking about that in the near future. It's a core feature of treating insomnia. And then I do this a lot less than I used to because there's a lot more variety of mask apparatus, a lot more automation of the pressure settings, but some CPAP therapy habituation, and then graded exposure, right? So particularly folks that have trauma histories, you can have that claustrophobia for having something on your face. And so different from habituation, but similar. Okay. So also have a separate competency in CBTN or CBT for nightmares. Kind of the primary conceptual theories behind this are cognitive processing therapy for trauma-related nightmares. About 75% of individuals that meet criteria for PTSD will also meet criteria for a nightmare disorder. The thematic underpinnings usually are somewhere around safety, power, control, trust, intimacy, esteem, or the lack thereof. There's always a symbolic meaning to this as well. It's not literal, it's not practical, it's not rational. There's cultural meanings, there's religious meanings, and then there's personal meanings as this person's life story and what that means for them. It's usually those big 5. And the other one is mood matching, kind of idiopathic nightmares outside of the context of trauma, but there's also some relevance even with idiopathic nightmares. But idiopathic nightmares is more mood matching. Like, what is my affective emotional state when I'm going to bed? If I am feeling very distressed about work or finances as I'm going to bed, there's a chance thematically that's what I dream about. If I'm feeling very depressed when I go to bed, similarly thematically, that's what I'll dream about. And then kind of the core stages: relaxation, exposure, prescription, image rehearsal. The only time that this is contraindicated if you have a patient with PTSD who's simultaneously going through an exposure protocol for trauma therapy. I'll usually hold off on that because it's just too taxing for patients, but that's usually the only contraindication. Okay, so what is stimulus control, right? The sleep environment. So being a stimulus or a cue for your brain when you stimulus control, where it's just associated with rewarding activities, right? In the context of insomnia, you start spending extended wakefulness, high frequency, chronically, and then all the associated arousal. It's multifaceted that we had talked about. You also are really tired. You don't feel like doing things. And you start to lose discriminative value, right? All of this starts to seep in. Start working in bed, start eating dinner in bed, spend a lot of time worrying in bed when I wake up at 4, can't fall back asleep. So a big part of the stimulus control work is conditioning, and that's the important piece. Conditioning doesn't happen overnight, pun intended. Those positive relationships with the sleep environment again. Sleep restriction is then adding regulation and most importantly, increasing sleep drive. So restricting sleep opportunity. This is the parallel behavioral treatment package to stimulus control. Again, getting back to those behavioral compensations, people are constantly playing catch up in the acute, right? From either disturbed sleep or insufficient, and usually both. So at a basic level, it's constricting sleep opportunity relative to the average total sleep time. This is statistically driven over several weeks before you make this decision. But what are people doing, right? Get into bed at 9. Takes me a while to fall asleep. I maybe have 1 or 2 sleep cycles, and then I'm awake for 2 to 3 hours. Well, what's happening during this period? They are accruing sleep pressure or sleep drive again. So eventually, they're able to fall asleep again. And then they'll have a bigger, and then they have an early morning awakening, an hour or 2, then they fall back asleep again. Over time, this happens long enough, right? This is a more micro level of catch up, right? But there's just a lot of conditioning of bad associations that are occurring. Very few people are actually leaving the sleep environment during this time. What are a lot of people doing? Getting on their phone, looking at the news, looking at social media, right? All things that are emotionally arousing, kind of this additional conditioning and compounding of negative associations. And there's a variety of ways to calculate sleep restriction. It's not overly complicated. Again, at a basic level, it's just restricting sleep opportunity down to, on average, the total sleep time. Usually never go below 5 hours. That's when you start to induce dangerous levels of daytime sleepiness. Sometimes we have to do it, but that's a rare case. So what are we doing? I don't have enough time. This is a whole talk in and of itself, how we really are focusing on the 2-process model of sleep regulation. It all relates to timing and duration of sleep in a 24-hour period, both the homeostatic and the circadian related factors. That's what stimulus control and sleep restriction are doing, is they're enhancing both of these processes. Again, all about timing and duration of sleep in a 24-hour period. And most importantly, getting back to that original slide, starting to slowly infuse back in a regularity and rhythmicity. So kind of the next level in the dismantling research of efficacy in terms of treating insomnia is the cognitive piece. I very rarely implement like a structured CBT cognitive technique. Now, if you read the manuals, there's a lot of them you can go through. I think the sleep diary is the template for addressing all of the maladaptive thoughts or attitudes or beliefs that develop over time. It's understanding what they are through the interview with the person, and then using the sleep diary, and I'm getting a check-in on a weekly basis, kind of, well, tell me about your experience of sleep since last time we saw each other. And then I have the objective data alongside of it, and we can walk through it. And that also is a process over time. You'll see a lot of this. Sleep effort. The godmothers of behavioral sleep medicine says, you know, sleep isn't something that we do. It's something that occurs to us in a 24-hour period. All our job is to do is just to create the right conditions. So more often than not, we get good sleep. But you can't exercise yourself into sleep, right? Or out of insomnia. You can't meditate. See that a lot. You can't deep breathe, et cetera, et cetera. I see a lot of people that have a caffeine sobriety for like a year before they get to me. Also not helpful, doesn't work. And then this will be another big one as well. So this surprises a lot of patients when I tell them this, but obviously I don't want something negative to happen to them, but I love a sleep disruption or a sleep disturbance when I'm working with an individual. I hate it when they go from appointment 1 to appointment 4 in remission and we're done. I want them to have to be able to really implement these skills because they're going to need to in the future, right? They've had a regression, right? Like, like a car accident or illness. I see that all the time. Or a parent was hospitalized, right? Sleep regresses. Okay, well, now let's use the stimulus control skill set and watch you slowly get back to wherever your previous sleep gain was or back into remission. And then those individuals have that evidence there, right? They don't need me for that. All my job is to give them that skill set. So I love to see that. I sometimes see this occur. We'll schedule a primary care appointment, and then we get a prescription alongside when I'm working with someone. I strongly encourage you to not prescribe a sleep aid when that occurs while you're working with me, because that's the antithesis of the skill set and that sense of self-efficacy that you can tolerate a transient brief sleep disturbance, right? Or sometimes I'll see someone finishes with me, they have a sleep disturbance, a year later or whatever, and then they get a sleep prescription again, right? Those are those moments, those appointments where I strongly encourage you all to either re-refer to me or just emphasize this skill set, right? Well, what about stimulus control? Have you been using that? Et cetera, right? And it will wash out. If they continue to use stimulus control, they likely can get back to where they were. But the big piece of it is tolerating the variability of how people can tolerate the sleep disturbance, or more so, kind of that resumption of daytime symptoms. Okay, so I got to ask kind of like, what's my approach to this other than kind of implementation of the evidence-based approach? I'm my oldest daughter was born 7 weeks early. We were in the NICU for quite a while. I was like, life put me on my knees, right? And a really wise friend of mine talked to me about parenting when I was feeling generally helpless. I don't know if he knew it at the time, but he was talking to me about Alice Gopnik's work, right? The gardener and not the carpenter, right? And it really fits kind of with the conceptual framework of parenting, right? We shouldn't be carpenters, right? I have 2 daughters. They're 2 completely different people in every way, and so similar in so many ways. But they are who they are. And my job is to guard, not to make them who I want them to be, but to influence them into who I want them to be, right? And again, getting back to what I was saying with, I love this in my protocols. I want this, right? Those are learning opportunities. And then this is more kind of secure. I think this is more kind of like a attachment based term. I like stable, but I think all humans need that. All animals need stability, safety, kind of love, right? Whatever that looks like in the animal world, depending on the species. But I just think we all do. So that is something that I also try and incorporate into my treatment protocols. I regularly get the kind of the patient feedback, never felt judged, never felt judged, never felt judged. That is so important to me. That is the feedback that I care the most about, because people are doing anything they can to sleep when they get to you. I'll see folks who have their prescription sleep aids and they're also using alcohol or cannabis or Benadryl or name the over-the-counter sleep aid, just to try and get some sleep, right? I get it. You're just trying to sleep. So how you make that person feel is so important as you introduce the science and start to develop a skill set so they can handle it in the future without all of those sedating substances. I also grew up on a farm ranch in Montana. And my parents raised and trained quarter horses. And so I had the privilege of going to some of Buck Brannaman's trainings. I have this vivid memory as a kid. I think it was my dad this time. Anyways, there'd be this big corral and all these individuals were riding their horses, learning from Buck. And I remember there was just this guy who was like jerking his horse around, and he was trying to be a carpenter, right? He wasn't trying to be a gardener. He was really frustrated. Buck could tell. He came over. What's going on? And this guy's like, "Well, my horse won't do what I'm telling him to do." Buck's like, "Get off him. Let me see." So the guy takes his saddle off. Buck puts his saddle on, gets to know the horse over a couple minutes. And Buck gets the horse to do exactly whatever the skill set was that he was trying to train the riders to do. But the point was, it's about understanding the animal, communicating with the animal, and it's about the relationship, right? It wasn't getting the horse to obey, right? So again, similar to my approach to treatment protocols. Right? It's not kind of lack of adherence, right? It's like, what do I need to do to be able to flexibly adapt my treatment protocol to help this person start to utilize these skills? Like, I'm a firm believer in that. There's so many articles now on insomnia as well. But in the Atlantic last year, Jennifer Senior, who has had insomnia in the past, I just love this article. I think it was beautiful and just so well written. But it just talks about the daytime experience, right? That symptom burden, right? That kind of the grouchy slug is what I like to call it, right? It's so hard to enjoy things. And a lot of patients will say it's just like everything's so effortful, right? You just slug through your day. And then Maya Angelou, I kind of touched on this, but I really believe that a lot of the skills, it's obviously you'll have a lot of patients remember, like all 6 features of stimulus control, but it's mainly making them feel understood, not judged, and that they can do it, right? They can handle the next time they have a sleep disturbance. I also grew up on a Native American reservation on the farm ranch in Montana. When you understand kind of the myths and tales of many tribes in the United States, it's also all about allegory, right? Or symbolic representation. That is how our dreams work. So this was a really amazing book that I recently read, but it just fits perfectly with the work that I do for nightmares. Not going to spend a lot of time on this, but sleep need is much more complicated than just kind of current ability, or I get them when you refer for insomnia, or opportunity, or how opportunity is constantly adapting and shifting as people are compensating. The one thing I wanted to really point out to you, if you're going to do some basic questioning around insomnia, is what we call social jet lag, right? So what's happening for a lot of individuals? They're not getting enough sleep during the work week, and then a lot of catch up on the weekend, and they start all over again. Or you see this with youth a lot more. It's just so irregular. Kind of another way that you'll see this for your guys' work is in the context of like medical leave, right? People's sleep-wake schedule, when you lose the structure of work, it just becomes irregular. You also see a phase delay. I often see that, right? Kind of slowly going to bed later, slowly waking up later. But this is the big one to watch out for, is the discrepancy between sleep on days off and during the work week. Okay, so screen, and screen some more for sleep. Here is the European guidelines, kind of an overview of some basic questions to ask, right? At a very basic level, I know you guys have so little time in any given appointment, but at a minimum at the annual visit, any difficulties falling asleep, kind of your benchmark, more than 30 minutes on average. Any difficulties staying asleep, 1 to 3 awakenings, very normal. Associated time awake, more than 30 minutes, kind of maybe more than 45. How much sleep do you think you're getting? Probably not going to be very accurate on this, but if you really want some fidelity, have them use the app that I use. It's open source. Have them fill it out for a couple of weeks before they see you. And then you'll have a sense of where their sleep is at versus kind of this omnibus retrospective look, which obviously we all are not that great at. In terms of sleep disorder screeners, this is what I use, the SD SCL25. I have a smart phrase that I'd be happy to share with everyone. Built into Epic, also I think would be just a great addition to any annual visit that you see. Oh, at your annual visit for 50 compared to 45, you're at greater risk for sleep disorder breathing. Maybe we should make a referral to pulmonology sleep medicine in addition to behavioral sleep medicine. ISI, also built into Epic. I would encourage you all to be giving that if you're not already. Insomnia Severity Index. ESS is also kind of a really helpful adjunct to the stop bang if you're going to be screening for sleep disordered breathing on any given annual visit. Okay. I've gone to quite a few CEs around this or CMEs recently, your guys' acronym terminology. Emerging subspecialty is women's health and sleep. Like there's just so much to learn here. Kind of more thematically for us, it's don't just screen for sleep during life stressors, right? Like a divorce or a bankruptcy, or you just had a knee surgery, right? Where we would expect there to be a sleep disturbance, but just the normal life transitions, right? In women's health, that there's this normal interval to some of these things, but really the menopausal transition is so important to focus on as well. We just have this emerging literature now that sure, men are at greater risk for sleep apnea prior to the menopausal transition, but women's risk has a stepwise increase at that time. I mean, and it's just not really being screened for because we just didn't have the literature for it yet. And the symptom profile is also different, right? It's phenotypically looks different. And so women can be diagnosed with other things rather than being screened for sleep apnea, right? In men, it's the typical daytime sleepiness, the apneic events at night. But for women, it's more subtle. It can be fatigue, insomnia, depressive symptom constellation. Headaches are really common. So they get diagnosed with a headache disorder or with depression, or, rightly so, insomnia, but it's insomnia associated with, right, sleep disorder breathing. So another factor to screen for with this particular patient population during this life transition. I spent a lot of time talking with female patients kind of in this age range, not, dissuading them from HRT, but maybe also talk to your primary care provider about screening for sleep disorder breathing in addition to HRT. Okay, and then the de-prescribing, so important, right? Kind of the ACP's recommendations around moving away from medications, right? CBTI frontline. But a lot of the published literature was more about kind of starting and switching medications rather than evidence-based practice guidelines on how to de-prescribe. Well, in 2023, the UN and WHO changed that. I love this manual. I encourage you all to start using it. Psychiatry colleagues here at Psychiatry West at Providence also are big supporters of this as well. It doesn't cover each drug class where you can commonly see prescription sleep aids, but it covers a lot of the big ones. It's just so well done. You'll see a lot of the taper schedules if you refer to me. If you look at the notes, I always send my intake and my discharge notes. You'll see a lot of the taper schedules embedded in my treatment plans, and it's from this manual. I'm also seeing more of this. So something else I just kind of wanted to briefly touch on with you guys, kind of as it relates to patient motivation, patient readiness. If you're trying to encourage someone to get off a 20-year Ambien prescription, but they don't really want to engage in CBTI, then there's a kind of a conflict of interest there, right? There's a good chance they're non-responders and they come back to you. Okay, well, CBTI didn't work. Let's start Ambien again. So just being kind of mindful of some of these third-party kind of decision trees. Okay. Also, this is an emerging literature as well, but just commonly prescribed medications that can influence sleep health. So this was a really great review. It didn't cover all of the commonly prescribed medications in primary care, but it covered a lot of them. And so something I wanted to just add for you, I'm sure this is something you're all aware of. I was talking with Laura a little bit earlier as well. The anticholinergic burden calculator is something also I encourage you all to start using. It's open source, online, evidence-based, and it's a wonderful tool that I use to talk to patients around polypharmacy, and then particularly as it relates to sleep aid prescriptions to increase motivation readiness to start to taper off sleep aids. And then lighting. I get asked about this a lot. Blue light, actually, we had these old expert consensus, like stop blue light exposure an hour before bedtime. Well, unless you're, an adolescent right now that's on your switch for 4 or 5 hours, 10 inches from your face, that degree and proximity of blue light exposure is probably the only behavioral factor impacting endogenous melatonin release. But if you watch a show before bed, it's likely irrelevant. More so, it's just all of the artificial light exposure that we all have in first world countries and then in the digital world. So kind of progressive reduction in lighting, really helpful for Delmo or endogenous release of melatonin. I think this would be great to have in every clinic, outpatient clinic. I checked the library. Unfortunately, we don't have a copy, but again, this is really helpful. Like, what does insomnia look like in cystic fibrosis and cerebral palsy, et cetera, et cetera. It can be really helpful, quick reference guide. This was also recently published, just a textbook designed for those in public health and primary care. Again, just a helpful, quick reference guide that might be helpful to have at any given outpatient clinic. Dr. Nieto is actually at Oregon State. Okay, and that is my talk. Thank you.
Thank you so much, Dr. Duffield. We'll start with questions here in the room.
That was very helpful. Thank you. So I think that you already answered this, but it sounds like a referral to you for someone who is reluctant will backfire.
Quite the opposite. I actually really, but thank you for that question. I normalize ambivalence. So I'll have a lot of patients when they finish just because of unfamiliarity with CBTI, behavioral sleep medicine, and honestly, even more so in professionals. What, you're sending me to a psychologist for insomnia? Like this, how's this going to work, right? This is a medical condition. So, I roll with the skepticism. Yeah, like ambivalent, sure. Like that's okay. Again, building trust, building the therapeutic relationship is what's most important. The sleep diary, above and beyond some of the basic therapeutic skills, will always do that for buy-in, right? As they see their sleep getting better, their data, and then even more so as they start to feel better, and then it becomes self-reinforcing. But I'll have a lot of patients at the end of the appointment or at the end of a protocol who'll say, I thought this was BS. I still don't know how it worked, but it works. There's a big learning curve along the way as well. There's so much of the sleep science that I briefly introduced to you all today that I very intentionally introduce as we go when I'm working with someone over 6 to 8 appointments. And at some point, it starts to make sense, right? The why of why I'm asking you to do this and why you should use it for the rest of your life.
Got it. Sorry. So should we separate out like the person who's been on their Ambien for 20, 30 years and thinks it's great, but we don't think it's great?
Yeah, so again, this was kind of the impetus for Dr. Nayak asking me to speak. I think they're the ones who need to see me the most, I would argue, right? So at my former employer, there was a lot of, I shouldn't say a lot, but there were some CBTI providers who would not touch patients that had bipolar disorder or refractory epilepsy or had a major TBI. Oh, well, you can't do sleep restriction with them. Well, you can, right? You have to be circumspect and thoughtful, and very data driven, but they're the ones who need it the most, I would argue. Yeah, but yeah, you know your patients really well, right? There obviously are some patients that they'll just never have the motivation. But I always like being wrong after an intake appointment where I don't think this person will get there. I've had many instances of individuals who halfway through a protocol change their mind about tapering off Lunesta. Or I always tell patients, again, my door's always open, right? I get you into insomnia remission, but you don't want to get off Ambien. Come back and see me when you're ready. And I've had quite a few patients come back, whatever the time interval later, when they're ready and then taper off. So again, I take a harm reduction approach. There's never a wrong time to plant that seed, right?
Thanks so much. Just to piggyback off of that while I take the next question, do you have some language that you can give us perhaps as we talk with a patient? Right. Sort of, we don't want to say, go see the sleep hygiene guy. Do you have kind of a one-liner or a couple lines to best encapsulate what the referral means as we're talking to a patient about wanting to make this referral?
Yeah, so I kind of, somewhat jokingly, but also not jokingly at all, like it's not sleep hygiene, right? But I think it's, so I don't necessarily have a one-liner, but it's skill-based, right? Like you are going to learn skills and getting better sleep affects all health, right? And I'm a big advocate of staying away from the shoulds as well. Like you should, right? Well, obviously you should stop your 20, 30-year Ambien prescription. But that instantly creates a defensive posture for patients, right? So I'm always gauging right when I see someone, and I know it looks different for you because you have to be more of the bad cop. Dr. Nayak and I have kind of joked around this before. Like I get to be a little bit of the good cop, right? Like you should get off your Ambien prescription. Where I have the luxury of being like, well, it'd be really helpful, right? I think it'd be good for you. We should consider it, and I'll check in. But again, that's where we start to have more of the interdisciplinary care, where maybe there is utility in you being a little bit more of the shoulds. Yeah, thank you for that question.
I think it's very, excuse me, like there's a lot of stuff in the zeitgeist about optimizing sleep with like wearables and
Yes.
A lot of the data around what people collect on their own. I guess that's one part of my question. If you found any of that to be like legitimately helpful, or how if you implement any of that. Second part of the question is like it can be hard to get people into CBTI like
Yes.
professionals, and
Yeah.
so I tend to give people the app like this. I forget I don't know. There apps that help with this, or at least I've been told help with this. So that's the second part of the question.
Yeah, thank you. Both great questions. So the first, there's term in the literature now, orthosomnia, right? So not all data is good data, including big data, right? Particularly as it relates to the reliability and the validity of the sleep continuity and sleep duration metrics that you will be getting from your wearable or whatever the software health tracking package is. Now, a lot of those algorithms have improved in the last decade for a lot of the commercial products. Oura Ring's probably the best out there. I think they did their due diligence in the validation studies, but it's overwhelming the amount of apps that are coming out now that there's always that proprietary screen, and it usually causes more harm. I find that it's a talk in and of itself to kind of go through the reliability, validity statistics of the sleep diary versus the wearable data for sleep continuity, sleep duration. At a very basic level, the wearables will estimate sleep onset latency with a greater reliability, validity, but they really lean into the sensitivity of the instrumentation that they use to get that level of reliability. So then they give up specificity. And so then it causes a lot of problems in terms of estimating frequency of awakenings, total time awake, and then total sleep time as well. I've gone to a lot of CEs around this recently as well. It's probably in the near future where technology will surpass the reliability, validity of the sleep diary. It's not there yet. And tell all of your patients to ignore the sleep depth data. Even Oura Ring, I'm skeptical. But polysomnography obviously is the only way to validly measure sleep depth. And then access, kind of your second question. It's a problem, right? I was talking with Laura. That's my big worry after this talk, because I'm just assuming there's a lot of primary care providers who don't know about me and are going to start referring to me. Well, yeah, I mean, that's a great thing, right? But patients already are frustrated with me about how long it takes to get in with me. So we just posted a position for a second sleep psychologist last week, more of a woohoo, and that'll be great. And we're trying to build a tiered model of care as well. So some of the local BHIs, there's many who do have CBTI training. I'm also going to do a CE series for the BHI department, just so we have more with basic training, right? So you can start locally, and then just given the chronicity or the complexity of the case, consider referring to me. We're also trying to get 2 groups going. I believe one just started in Lake Oswego. I think it's only offered to the local patients. And we started a second one that just didn't fill. So I think we just need to do a better job of just making you all aware of it. But I'm really mindful of that as well. It's great that you'll start referring, but if it takes 2 years to get in with me, kind of what's the point, right?
Any utility for any of the self-paced programs to help increase access, apps, books?
Yeah, so if you go to ASM, there's now an app, I can't remember the name of it, that now has FDA approval. There's one out of Harvard as well, also can't remember the name. It's just hard because, I mean, I'll have professionals who will come into my office with a manual, right? And they've got, bookmark this, and that. And to get back to your question, are just marvel that going through 6 appointments with me, they actually are now in insomnia remission when they couldn't do it on their own, right? They're high functioning, intelligent individuals, and they just expect that this is just another problem they should be able to solve. And I hope I've communicated it's really not that simple. So again, not dissuading you from offering that to patients, but I just think it takes a certain person to really benefit from that. But again, in a tiered model of care, when access is a problem, kind of why not start there? It's just kind of the harm, like I just don't feel like we really know kind of the potential harm, particularly as it relates to some of the maladaptive thoughts and beliefs around sleep with the technology there. But again, just given current access, I think it's a great place to start. CBTI Coach app is open source, developed by the Department of Defense and the VA. It's what I use. And it was also developed for service members to be able to get started working on their sleep, to also have a library of resources embedded within the app until they are able to get in with someone like me. I have also a workflow there. If anyone's interested, I'd be happy to share.
Well, thank you so much for getting us started, and thank you for what you do.
Thank you. Thank you, everyone.